afternoon. We're back. This is the Center for Plastic Surgery. I'm here with my good friend, Dr. Steve Thomas, Dr. Trevor O'Brien, having a glass of wine at the beautiful Chateau Chantal on Old Mission Peninsula. And we're out here in July. It feels a little bit cooler than that. It's an overcast day, and there's a bit of cherry picking going on, so there's a little bit of background noise, but we really appreciate this group and their proprietors for allowing us to come use their facility and have a couple glasses of wine and pick up where we left off and talk a little bit about plastic surgery and Traverse City in general.
Fantastic. Let's do it.
So we're going to jump back in because we've had a little bit of feedback from the last time we did this and a couple of questions from staff and patients and friends. And one of the main ones comes back to, you've been in Traverse City for 26 years, and you were attracted to this region for the obvious natural beauty. This is a gorgeous spot. But what else? Tell me about what attracted you to Traverse City in the early 90s, and specifically about surgery, plastic surgery. How did that look? What was the landscape in Traverse City in 1992?
Well, the simple answer is my wife attracted me here because she had been here many times. We heard about this job here. She said, you have to go, jumped up and down, clapped her hands. I had never been here in my entire life. Visited, loved the area. It's, as an outdoorsy person, ice fishing, golfing, fishing, hiking, hunting, this is a great spot. The landscape was a really big difference from then to now. It was a smaller hospital. The services were growing. They were trying to recruit more people, and actually they're trying to, I believe, making a conscious effort to recruit younger people. And there was one plastic surgeon, Dr. Tom Dorr, you know Tom Dorr, and he was overly busy. He could not handle everything. So from the standpoint of a young plastic surgeon, if you looked at it, you would say there's a busy, I don't want to say older because I don't want Tom to see this and get mad, but a busy plastic surgeon was more mature than I was and couldn't handle everything. And I brought a couple of new techniques to the area. And so I said, yeah, I'll take it. It's a good opportunity as a young guy because you've got something that they're not doing completely. Like I brought microvascular surgery and a lot more techniques in breast reconstruction. Was attractive from that standpoint, especially. There was a significant component of camaraderie at the time. I think that the one thing that I've seen is as the facility has grown and gotten bigger, the interdepartmental, between general surgeons, internal medicine docs, etc. I was told I had to memorize everybody's name by the chief of staff at the time. He says, you have to know everybody's name within a month.
Yeah, it was probably really good for you.
It was, because I would look through the picture book and try to figure out who was
I remember that even when I came. We had that conversation. I remember this case that you did with Mike Colburn, a trauma case at night, and I thought, wow, this is really collaborative. This is really cool. I was actually attracted to that too. And now Trevor's kind of the new guy. He's seen it evolve. It's a different ballgame. People have been asking about more of the high-level procedures, the kind of things that you hear about. Oh, that you might get that in Miami or something. What are the kind of things that you've seen in the last year or so that you say, wow, that's big city?
Yeah, I think big ones in the body contouring realm being, high definition abdominal etching, high definition liposuction, trying to create a six-pack with liposuction alone.
Yeah, so how do you do that? So for the rest of the audience who's listening, what's the technique for that?
Yeah, so you do traditional liposuction like you would, reduce the fat volume down to appropriate level, but then, essentially you're sculpting and contouring a six-pack by thinning it out along the areas where you want it thinner, just to define essentially what looks like a six-pack without them actually, doing the work to get a six-pack. I've seen consults for calf implants recently.
Really?
Yeah. It was a traumatic guy with a history of traumatic injury to his lower extremity, so he couldn't develop his calf muscle, but he's a bodybuilder and wanted some more calf definition. And then a few cases of some gluteal augmentation with fat grafting.
Yeah, fat grafting the butt. Actually, I've heard of that a bunch recently. I had 3 cases in the last week or so.
Yeah.
And where people, honestly, you've seen this over the years, probably people kind of said, oh, I'm interested in this certain procedure, but, oh, I'm just kidding. And now
they're serious.
They want that procedure.
They want it.
How about you? What have you seen that's kind of different in the last couple of years?
I think the last couple of years, the big difference is some of the non-operative facial cosmetic surgeries. You know, and I think you brought a lot of this with you when you came. You know, the microfat grafting to the face, the combination of lasers, microfat grafting, maybe a blepharoplasty and eyelid surgery to make the eyelid look a little neater. And I think that was something that was kind of a new concept. You know, we all go to meetings, we all see the new things, and when we go to these meetings, you see something new, something a little different, and it's usually not something that's majorly different. It's usually something that's just a titch off of what we're doing. And then you get here and you say, I want to try that, and then somebody new comes and says, oh, I do that all the time, I know how to do that. And you go, excellent, let's take care of that. And I think that's the area that's been really evolving. There's
some little pieces that go with something. Somebody says, oh, okay, I'm interested in eyelids. But then you look at it globally and you think, well, no, wait. But there's a little bit of volume loss here or there.
Exactly.
And have you thought about this? And of course, you have to have the technology. I mean, you have to have the pieces that can treat something, because nobody, well, not nobody, but let's say nobody wants a full reconstruction. So you have to have the pieces in place. But then you say, well, then, yeah, we could layer these things in.
Yep.
And what I've been fascinated about is in the last couple of years, since we've had an office operatory suite, fully accredited suite, anesthesia providing on-site, suddenly you have these technologies in the office and you can employ them. And you say, okay, I'm almost done with this, but I want to bring in this technology, a microneedling, a laser particularly. That's been so cool, because now the sum of the parts when it comes to this, these are technologies that work great on their own, but when you layer them, that's
right.
the piece that I've been fascinated about.
And I love the OR at the office because it's really brought to keen insight the difference in anesthesia. When I came here all those years ago, if I did a facelift, it was in the operating room at the hospital under general anesthesia, intubated, and those are fairly long procedures. I mean, they're a reasonable fast surgeon. It's 2.5, 3 hours minimum, you know, and those were pretty long surgeries. And those patients did well, but you start looking at it, especially when they woke up, you know, they might cough a little bit, and that's where we run into problems.
Blood pressure changes.
Post-op nausea, all that stuff that
Exactly.
people fear. It's like if you don't have to have an operation, well, what are the upsides and downsides? One of them is if you're going to be nauseated, etc. No fun.
No fun, don't want to do it,
Maybe don't do it.
And nowadays, as you guys know, we rarely do anesthesia, general anesthesia for a facelift. And if we do, it's because there's some other mitigating factor, or we're doing other procedures at the same time. And what I found recently is we've really got a great repertoire with the anesthesiologist where they'll start the case with the general anesthesia, we'll do the case that needs the general anesthesia, and as we get towards the end of the procedure, they switch them over to sedation so that they can wake up nice and gentle and easy, and you just open your eyes and go, oh, you're awake.
I have to say, yeah, I've got a great partnership with our anesthesia providers. We use strictly the anesthesiologist through the Traverse City group, and they're really good about selecting the right patients for the right setting. But when we can do it in our office, again, the familiar setting is nice. The familiar staff is what the patients have given me some feedback. I don't know if they've said to you.
Oh, definitely.
They say, yeah. I met
by first name.
Haley.
Yep, exactly.
I met Leslie. I met all the girls, and they met him at their initial appointment. They see him the day of surgery. They see him afterward. That's been a really neat thing that I hadn't predicted, but I really appreciate that.
It's a comfort level. They come in, they're comfortable, they have the surgery, they're comfortable, they're seeing the same people again and again. It's like seeing a family.
And a routine.
Yeah, it's a boutique setting, it's private, you're not going to this big institution.
Yeah.
But yeah, it's been
So that's been a neat thing. So we've gotten that evolved over time. I think that's a really modern technique where we're having people into the office for a lot of these procedures, but finding the right ones that have to go to a higher level of care, fine. What do you think? So Steve, you've been excellent at what you do for a long time, but at the same time, and I got to tell you, this is an honest compliment, I think I'm maybe most impressed by the fact that you have never sat on your laurels. You have never stopped at what you learned or said to yourself or said to me, I'm in this great town, people think a ton of me, I can kind of do things the way I've been doing them, and that's it. You've been to meetings, you've gone out and sought out new technologies, new techniques. So I'm impressed, but I want to hear, what do you think is the next new thing? How is this going to go into the future for Traverse City and for our practice as you transition away from it
Yes.
shortly.
Well, you know, the important, at first, trying to go out and get new things, I think was out of fear. Really. Because you're coming up here and you're thinking, I am in a fairly remote area from all the big cities down in the southern part of
nobody's
Michigan.
coming to help you.
Nobody's going to be here to help. I'm all by myself. So it was out of fear. You said, I have to make sure I stay up to date. Because I thought it was, if I'm going to treat patients, it's only reasonable that I stay up to date and have as much expertise as I can. And the caveat of that is when I didn't feel comfortable, I sent them downstate to somebody that I trusted, that I knew that actually did that procedure. The second part of it is you have to stay up to date. You know that as well as I do. You really have to always be on edge. You have to think about, if I do this, what did I not like about how it turned out? What was something that I thought last time and this time it was good, but could it be better? And then you have to go out and find out, what do you do to make it better? In the future, first of all, I think a lot of our learning in the future, as you've brought to me, we've watched these videos on this relatively new brow lift that we're doing. I had to go to a meeting. I'd fly down to Miami. Of course, there would be an opportunity for my wife to go with me too. But we'd go down to Miami, we have to go to a meeting to see a new procedure, and talk to a person. Nowadays, we can get a video ramp up or even see it live, ramped up, which is just kind of weird for me. I'm old.
Yeah, it shortens the learning curve.
It does, it really does. So that's something that's currently new and probably will get better and better in the future. I think the long-term thing that we're going to see is probably changes how we understand the way tissues react to the things we do. I'll give you a good example. We talk often about rhinoplasty, and when you think, and rhinoplasties are really, really hard. Doing a nasal surgery is super difficult. In the past, when I was trained, it was just take this out, make this look cute, petite, and that's completely changed, as you all know. Now we don't do that anymore. Now we say, how do we keep that nose, make it a little bit better, make it look better, but still the same nose? And I think we've been kind of going by the seat of our pants for a long time, and you start to go to some of the newer talks, and what they talk about is just making the incisions makes the nose change a little bit. Just making the flap go up in the air makes the nose go up in the air just a little bit. A little tiny trim of the cartilage makes this happen. I mean, I saw a talk recently where they said dissecting the cartilages out just changes the nose. Just put it back together and it actually changes the nose the way the shape it goes.
Leave it back the same way and it still
looks different.
Because at the end of the day, the secret bottom line thing in plastic surgery was, if you're taking something away, it's way easier than when you're adding to or trying to change the form of something.
That's right.
I think you taught me that early, and that's a guiding principle. But I want to back up just one second. Talk about that brow lift that you guys are doing, because it's been recently I've done a couple, but the classic coronal brow lift, which is an incision across the top of the head, ear to ear, to really lift up on things, is way out of style. It's kind of
big scar,
talk
big
about
recovery.
what you want to do now.
Yeah. So, you're facile with an endoscope. I'm
even
not.
That's kind of getting out of style.
Yeah, and you're limited on the foreheads you can do it on. You need a shorter forehead, not a big, big curvature to the forehead. So you're kind of limited on your patient selection there. There's this famous ENT head and neck facial plastic surgeon who's trained with an endoscope but developed this new technique.
Endoscope's like a gallbladder.
Endoscope, it's a little camera
so
device.
You're looking at the anatomy,
exactly.
But you're not making a big incision.
Exactly, but it's not a bent camera, it's not a curved camera, it's a straight camera. So again, you're limited on some of those anatomic differences. This guy developed this new technique through 3 or 4 total, small centimeter to centimeter and a half incisions. Essentially elevating the whole brow, reshaping the brow, really giving someone a youthful look back with minimal incision, minimal healing, but his results are pretty astounding. Dr. Thomas and I, Steve and I in the operating room 2 weeks ago.
2 weeks ago.
Yeah, it was his idea. He told me about this procedure, kind of mentioned it to me.
I found it on the website. The meetings and
I know, it's awesome.
Now, does that brow lift get you out of the realm of neurotoxin like Botox?
Yeah.
It does?
Yeah, because you're dividing a lot of the muscle, so you're essentially eliminating. You don't have to worry about paralyzing it with a chemical, neurotoxin.
Routinely, again and again and again.
Repeatedly, you're permanently dividing that muscle and weakening it.
But see, interestingly, so in my opinion, tell me about your how you divide this up too. I'm very interested in the concept of a little lateral brow lift out to the side, skin only lift, and I say to people, but the neurotoxins work so well, we're still going to be interested to treat the 11 lines and stuff like that, because for a lot of people that's like getting your hair done. I mean, it's just a simple thing.
It is a simple thing. I believe that, as you know, we really have gone away from those big lift your scalp up type things. Matter of fact, when people would ask me about it, I wouldn't tell them about it, and we've mentioned that before, I'd say, it's a big incision and leave it at that, because if they heard exactly how you did it, they wouldn't do it. I do like any of the limited incisions in the lateral brow to take care of that brow. And we don't really want to have a deer in the headlights look. You know that. We want to have something that's subtle. We just want to have that lateral brow up. The harder part's the medial brow, inside right here. And there's probably a time when, aside from just flipping the head scalp up and looking at those muscles and cutting them, we're still going to have to use neuromodulators like Botox and Dysport and Xeomin.
It's not as popular to go through an eyelid incision and go up and get that muscle.
I've tried that.
I mean, it's hard,
and it doesn't work very well. It doesn't last. It's just, I've tried it many times, and it's satisfactory but not perfect. Okay. So, and if it's not perfect, why would I keep doing it? Right. I don't want to do it. So yeah, it's a big difference. I have a question too. Go back to my perceptions of what we do and everything like that. We all look at TV, we see Botched and everything, and I enjoy Botched very much.
Yeah,
I think it's a pretty cool show. What do you think are the biggest misperceptions or misconceptions that the general public has about what a plastic surgeon really is?
I think the name, plastic surgeon, they think plastic, it's because you put in breast implants. First off, they're not plastic, they're primarily silicone.
Yeah.
Second off, it's based on the Greek word plastikos, or to mold, to change, to reshape. So I think that's a big, they assume it's plastic surgeon because you're using plastic.
I don't know how many patients have asked me, well, what kind of plastic you put in this time? I'm thinking, there's no plastic, we're not putting that in there,
I think that's a tough one, because that has raised the expectation level so high. But on the other hand, I think it's also upped our game because people demand something different, and that's okay. I think that's really kind of neat. I like that show. I think they have a lot of realistic cases, and of course then they throw the real wacky ones that are your 17th nose. I can't. I would never offer that, because I think that's a highly specialized niche. But the funny ones are the ones where they have the husband come in the OR and talk about the breast implant size.
What do you want? What size do you want?
That doesn't really happen. And the funniest thing is when we have people who come in and they're going to have a surgery, most of my patients say, and by the way, he doesn't want to come in to give the opinion. And I think that's appropriate, because we don't want anybody hitting the floor.
Exactly.
And that could happen. I think in some ways that has upped our game. I think that's brought to the mainstream a perception of what plastic surgeons can do, and I appreciate the fact that show has enough real cases, nicely managed, that it highlights what we do. And then people say, "Oh, I saw that on Botched, and I think it's very similar to me." And I say, "Yeah, actually, it kind of is, and we do that routinely." That's the one sensational thing, is that they say it's a real one-off and that they've never seen this bad a case before. Yeah. And actually, in Traverse City, Michigan, we see it all the time.
All the time, yeah. That's the one thing that has been very interesting is, as I've gotten older, I've seen more and more things that haven't gone completely right, and most of them are not in the area, obviously. Most of them are from, downstate, and they come up and they say, okay, I've done 4 plastic surgeons downstate, 3 plastic surgeries, and I still don't think it's perfect. And you look at it, and it's not like that I'm magic or anything like that, but I think a lot of times some of the plastic surgeons aren't willing to take enough time and really sit down and figure out what to do. And it's hard to do that. It's hard to go back and say, okay, I'm going to do this again for the 4th time.
It's tricky, but I will say honestly too, one of my favorite things is to be able to look at a situation and somebody has a concern or something that they think is isn't right, and they are influenced by those shows.
They are.
And I can say that it's a fun thing for me to be able to say, no, you look great. This is actually a great result. Sometimes people come with their before and after pictures, and you say, you know what, this is a really tricky thing that somebody managed as best they could, well documented, and you should be very happy with what you have. I'm happy to say that in a situation. I would never present it as a situation where we can say, oh, we know how to do it better. Not necessarily.
No. There's a lot of people out there that have unrealistic expectations. And one of the things that I believe we get better at as you get older is managing those unrealistic expectations. And probably the biggest thing is getting it from the start. I think the hardest part when I was a young plastic surgeon was figuring out how to say no. I can't do that. And it wasn't no that I wasn't capable of doing something. It was no, that's not capable of being done.
Yeah. It's different than just no. Yeah, it's not that. And Trevor's very, very good at this because he had spectacular training. But it's not a no. It's a here's what we can do, and realistically, here's what you should expect, and here's how I've done it 6 times before, and here's some photos.
And exactly,
that makes a good case.
Some of the technologies we have with photos and being able to draw on them, this new technology, the Lucio that we have, we can really say what's reasonable and what's possible for each individual patient. You know, not every patient can have the look of, you know, Kylie Jenner or you know, this or that. You know, their anatomy might limit you in some way, and it's nice to be able to use that technology to show them how that is. And really,
I get nervous when they say, "I want this nose."
Yes,
because I'm thinking,
exactly.
That's not your face.
Right.
Yeah,
exactly.
that's fairly tricky. Okay, so that's a pretty good overview of how we've evolved as a practice and things we're doing now. I have a couple of thoughts or questions, specifically from some of the staff who saw some of the previous talk that we had, and they have some questions. Okay. So Dr. Thomas is planning to transition out of clinical practice on what's the day?
August 4th
of
2021.
Okay. And we're sorry to see him go, and that's part of the reason we're here today. Is we want to get this on film. We want to get this for posterity. I'm interested to hear more of your insights, and I'll have to call you in the future because this is a big deal to me.
Okay.
But okay, so some of the lighthearted ones are, we're in a vineyard. Tell me about some of the. You're a wine collector, a connoisseur, but you also like bourbon and things, and you're going to have a house in South Carolina, so you have to travel through, coincidentally, some bourbon country. Tell me about wines and bourbons that you like. What are your top 2?
Top 2. Well, the good part is that almost exactly halfway from Traverse City to South Carolina, where the house is Louisville, Kentucky.
That's totally coincidental.
It just luck. Yeah. And there are a lot of bourbon distilleries in Louisville, coincidentally. I do like bourbon. I don't think I'm a bourbon snob, though. I think that, and this is similar in wine too, I think if you spend a lot of money for a bourbon or a wine, it should be very good. And what I like is when you find something that you say, this is really kind of a surprising bourbon or wine for the price that I've paid. And recently I found a bourbon called Old Ezra Sauvignon. It's made by Lux Row Distillers. It's spectacular. I just really like it, and it's not the most expensive bourbon in the world, but it is really difficult to find.
Is this a glass of bourbon, or is this a bourbon and Coke? Like, what's the?
No, it's no.
Okay,
no.
Just checking.
Neat or on the rocks?
Neat or on the rocks. Taste neat, and then put a rock in to get the full effect.
And ice is a big deal.
Yeah.
You know what the thing about the ice?
1 cube.
You gotta have
gigantic cube.
But the square or the round, but no air bubbles in the ice. It's a big deal. It's like where you have when you have a second cocktail and the ice is better the second time. It tastes better. Yeah. It's the ice.
Huh?
Yep, I agree. And I have those round bourbon ice cubes at home.
That's a big deal.
Yeah. I'm fortunate because, again, my wife likes bourbon as well, so that makes it easier for me. Wine, I'm all over. I like a lot of the white local wines are very good. I have some nice places in my heart for some of the Rieslings, the Gewürztraminers. If I had to pick a wine that I'm really partial to, I would pick a Zinfandel. And the reason I would pick it is it's kind of off the beaten road. And what I like about it, it's one of the oldest wines ever made in America. The monks planted them hundreds of years ago. And to me, it's just a plain old everyday fruity wine that you drink with a hamburger or a pizza. So that's what I like about it.
Okay, another one. You've told some of the staff, and specifically Haley, our nurse, that at some point you said when you retire, you want to write a children's book.
Well, that comes from children's stories and from having kids. So what happened was, it was driven by one patient too, so it's kind of a unique patient as well. But I would tell the kids stories at night when I was home to put them to sleep. And I really got tired of reading the same books over and over and over and over again. So what happened is I'd say, hey, look, there's a hidden book at the end of this book. And I would make a story up. And what happened is one time a little girl who I sewed up in the emergency room, I told her a story, and she brought in 10 colored pictures that she had made of the giraffe story. And the mom said, I have to know where that book is. I have to get that book. And I was like, uh-oh, that's a problem, because it's up here. So what happened was I've kept all those pictures, and I dictated to our transcriptionist all of the stories, and she gave me back a CD with all the stories on. So one of my goals is when I do retire, I'd like to get that finished and put in together. So, yeah.
So that's a fascinating story about the book, and I think that's really cool. I wonder, is that the most memorable case you've come across? Or tell us about something that stands out.
It's the most cute, memorable case, but I think memorable cases can be cute and scary at the same time. And as you all know, because we've all experienced it, when you get called in to do something and you think, wow, this is terrible, and I really don't even know where to start. For the people that don't know, we have to do a certain number of cases. They take our cases. We get examined by the Plastic Surgery Board of Examiners. They make us defend our cases in the beginning when we're first starting. And in my early, I think within the first year of me starting, there was a terrible accident in Traverse City. A young woman, 15 at the time, I believe, was badly injured, brought to Munson Medical Center. The neurosurgeon called and said, I need you now. And I literally walked in the operating room and could not figure out what I was looking at. And I thought to myself, I have no idea what I'm going to do here. I worked on her. We got her into the ICU. She did okay. I subsequently worked on her some more, and she did do very well. And I still see her today. God love her. I went to the board, the oral boards, and they reviewed that case, and he pulled the case up and he said, so this case is spectacular. And he said, but I have one question for you. When you walked in that room, what did you think? And I said, I thought, I have no idea what I'm going to do today. And he says, well, it was fantastic. So I felt pretty good about that. That's a memorable case.
Interesting. So do you have any advice? So we've run into something like that. You know, you get in an operating room and you just maybe it's unexpected, but just in general, I guess when you started in practice, based on cases like that, guys like both of us, and if we were to find someone to come along in your shoes, what do you advise for the plastic surgeon in the future of Traverse City?
My advice is, we all know this, we do this, is be cordial, not with each other and with the patients as well. I think the future holds some trying times for medical plastic surgery, cancer reconstruction and stuff like that. And I think that that's important for us to still keep doing. But I think that the plastic surgeons in the future are the plastic surgeon who maybe comes in from my spot is going to have to be cordial and be friendly. And I think most of all, be honest. I think honesty is the biggest thing. I don't know how many times I've looked at a patient and they say, so what is this? And I say, I have no idea. I can make a name up for you, and I could tell you something that's probably not right, or I can figure it out for you. And at first they're kind of taken aback, but as soon as you say, but I'll figure it out, and then we'll take care of it, I think honesty is the best thing.
Mm-hmm. Or you said before, this is something that, no, I don't know, let's make that better. You know,
right.
That's a hard thing to get to say. getting beyond any ego as a plastic surgeon that you see on
Right.
botch and that sort of thing, saying, no, I think I could do better, and let's give this another go, or let me try something a little bit different, particularly in those complicated patients, but even in some relatively straightforward ones, to try to give them an optimal result.
Right.
I think you've done that over and over, year after year. It's a real testament. And you've seen that. You've seen him do that. You've learned from that.
Oh yeah.
So I think that's
Definitely
been awesome.
want to emulate that. You know.
Yeah, I think you all do that. I think you do that too. You say, the hardest time is when somebody likes what you've done. You say, this is really nice. And you say, that part could be just a tiny bit
It's
better.
stuff about the eye that you have for it. Yeah.
Yeah, exactly.
Yes.
Exactly.
That part could be just a little better. And you do have to swallow your pride
You
a little
bite
bit and
your-
say, I think I should do that.
Well, hands off. Then sometimes you say, okay, very good.
Yep.
Yeah, you're happy.
Yeah.
You're happy. Yes.
And sometimes you say, no, I think we should just touch that. And some patients just say, nah, I'm perfectly fine. It's great. Let's go.
I think that's true. I think it's a Midwestern thing, isn't it?
Yeah.
I think it's an up here thing. It's you want to be part of a community, and you want to do well for your community and the people in it, and you want to give them the best result you possibly can, and that's how you've built a tremendous reputation and a great practice, and we benefit from it to this day.
I think you guys are doing exactly the same thing I've done. So you really do have a good feel for the practice. Trevor, you're young and you have a great feel for the practice. And Chris, I think you should just be a professional talker because you're great at this. You're great at asking questions, and B, you're a spectacular surgeon. So.
He's top 100.
I know he
That's
is.
Yeah.
Well, that's about all the time we have today. But I hope to do this again someday, and this has been fantastic out at the Chateau Chantal Winery on Old Mission Peninsula. Thank you very much for your hospitality, and thank you for being here.
Thanks for putting up with me.
Cheers.
Cheers.